Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is part 2 for safe blood product transfusion. Okay, the primary objective of this again is to reinforce the JCI, the Joint Chief International Patient Safety Goal number 1, identify the patient correctly. The learning objectives for this session are, we'll do a pre-knowledge review again, look at transfusion reactions, transfusing blood products, checkpoints for transfusions, observations that should be made during transfusions, and transfusion reactions that occur and what you would probably do in the event. Now remember, you do follow your specific hospital guidelines because every hospital, healthcare organisation has specific protocols when dealing with all situations. Let's do a knowledge review. Which of the following is the universal recipient blood group for packed red blood cells? O, A, B or AB? The correct answer is AB. Which of the following is the universal donor blood group for packed red blood cells? O, A, B or AB? The correct answer is O or 0. Which of the following is the universal donor for plasma? O, A, B or AB? The correct answer is AB. When thawed, fresh frozen plasma should be transfused immediately or within which of the following time frames? A, B, C or D? The correct answer is B. Which of the following is the shelf life for packed red blood cells if stored correctly? A, B, C or D? The correct answer is A, 5 days. Let's look at reducing transfusion reactions. There's a method, a technical term, leucodepletion, which removes leukocytes, blood cells that are white, from blood components using special filters. It's also known as leukoreduction, reducing the amount. You can't reduce them all, you can't eliminate them all, but you can certainly reduce them considerably or deplete their numbers. And the rationale is that leukocytes provide no real benefit to the recipient, but carry bacteria and viruses to the recipient, which can result in an immune response and a febrile reaction. So typically, following separation of red blood cells from the platelets and plasma, gravity and a small filter is used to separate the white blood cells from red blood cells into a different collection bag. And it depends on the manufacturer, but typically they're basically the same. They all go through a specific filter which is small to eliminate or reduce or deplete the number of white blood cells within the blood product, because this can result in a febrile reaction, which is the most common reaction that occurs during blood transfusions. There's also a technique called gamma radiation. And irradiated blood has been exposed to gamma irradiation to inactivate lymphocytes. This is typically used for intrautero transfusions, premature babies, immunocompromised patients, preventing transfusion-associated graft versus host disease. If we are going to transfuse blood products, we require medical orders. A physician has to write a transfusion order, and this has to typically include, in most organisations, the patient's full name and medical record number or order, the product, red blood cells, platelets, fresh frozen plasma, cryoprecipitate, the product quantity in millimetres or a number of units, the process details, meaning the duration, flow rate, whether they'll require a blood warmer or not. This is an example of a medical order, and every organisation will have their own. However, medical orders basically are the medical authorisation for the blood bank or the transfusion department to prepare the required blood product and for clinical staff to administer it. We have sample collection, and sample collection ensures patient identification is correct. Information in the request form matches that which is on the patient's ID band and in their medical history. They have to match. Sample collection also includes transcribing the patient's information from the patient wristband ID onto the specimen label. And this ensures patient identification information is correct and matches the request form, which matches the patient ID band. So all three match: patient ID, patient sample, and patient request form. ID, sample, have to match. Then we have an additional component. All samples should, according to the hospital policy of course, have a handwritten label rather than one generated by a machine or a computer. And it should be labelled at the patient bedside with the patient's full name, medical record number, the date and time collected, and your ID as the phlebotomist. When it comes to sample collections, never collect blood from a patient who does not have an ID band. Never leave the patient's bedside before labelling the sample, and if possible include the patient in the process. Never pre-label blood sample collection tubes before going to the bedside. A recipe for disaster. Why are samples rejected? Well, typically samples are rejected in most laboratories or transfusion units or blood banks because they are unlabelled or improperly labelled on the specimen. There's a discrepancy between the tube label and the physician order. The blood specimen collected is in the wrong tube, or the blood specimen is actually hemolyzed, or the phlebotomist has put the wrong volume of the specimen in the tube. Typically the laboratories will notify you if the sample has been rejected. I hope. So when we prepare blood for transfusing or a blood product, patient education is really important. Most organisations provide a transfusion brochure, the rationale for the transfusion, which include the benefits, the risks, any alternatives, the transfusion procedure, the duration, any adverse signs and symptoms that they should report, answer any questions asked. The patient and family must understand. This is called informed consent. And the patient and the family then make a decision. Informed consent. Baseline vital signs are very important as well. Body temperature is taken, pulse rate or heart rate is taken, respiration rate is taken, blood pressure, SpO2 saturations are taken and a pain score is noted. Remember, baseline vital signs deal with potentially life-threatening situations. Hypothermia, hypothermia, tachycardia, bradycardia, apnea, bradypnea, tachypnea, hypertension, hypotension, low saturation, high saturation, pain 0, pain maximum 10. It's important to have intravenous access. Sounds simple, but a patent IV access has to be confirmed. If you're taking the blood out of the blood transfusion unit or the blood bank, then there shouldn't be any delay in transfusing that blood. So check for the IV patency to ensure that the line is properly placed and the transfusion flow into the vein as intended. During this process, the transfusionist, you, should check for resistance, which can indicate blockage, pain, swelling of the skin at the IV site. As far as fluids and equipment, normal saline, note, is the only compatible solution to use with any blood or blood product. Dextrose and Ringer's lactate may cause agglutination and or hemolysis of the blood or components being transfused. And note, yes, an IV pump can be used with a specific blood set, but if it is being used, it has to be documented that it won't damage the red blood cells or the platelets. Normal saline is the only compatible solution if required to be used concurrently with a blood or blood product. Now, important checkpoints for transfusing blood and blood products are as follows. When you go to the transfusion unit or the blood bank for collection, the blood transfusion collection form, which all organisations would have, is the authorisation for the blood bank staff or transfusion services unit to release the ordered blood product to the clinical staff who collect it. All information must match. Checks include checking the blood product integrity as well. You check the expiry date and time. Sure, the donor, the blood group, the patient's blood group who's the recipient, and the date that it expires, and whether it's compatible or not. When you transport and handle the blood product, or blood, sounds simple. Transporting is from the time of release to the start of the transfusion. Blood and blood products have to be kept in an insulated transport container to protect them from damage and their temperature change. It's important that most organisations have policies that unused donor units must be returned to the blood bank or a blood fridge within 30 minutes of collection. Otherwise it can deteriorate. And if it deteriorates, it promotes bacterial contamination and this puts the patient at risk. Patient bedside checks. What does that mean? Well, what it actually means is that at the bedside, you're supposed to check certain things. Before transfusing the blood, you confirm the physician order of the product. On the transfusion requisition form, which all organisational policies indicate. The medical record number has to be checked on the patient's ID band, and the donor unit transfusion requisition have to be identical. Physician order, medical record number and donor unit. Everything has to match. Patient's name, medical record number and so on. Then most organisational policies state that there has to be independent double checking by someone who is now competent or accredited to give blood and a blood product. And this is typically registered nurses. So independent double checking basically means that you've got one registered nurse or healthcare practitioner who checks the requisition form, compares it to the patient's ID and the blood product. The other person will be checking it independently as well, not together, for the same thing. Requisition form, ID, blood labels, and it's important that any discrepancy, so for example you don't agree that it's correct, any discrepancy must be resolved before the transfusion is started. If it's not resolved, you return the blood. Independent double checking means that you have two accredited practitioners, in this situation two registered nurses, who are familiar with the procedure, and they check the requisition form, patient ID and blood product by themselves, and then another independent practitioner does exactly the same, and then they come together and say, yeah, it's the right blood product and it's the right patient. We can go ahead. So when we commence the transfusion, you've got to sign the transfusion record so that you've checked everything. You've checked everything here. So typically what you would do, there's a signature for nurse A and for nurse B. Nurse A typically is the primary nurse who's responsible for starting the transfusion, and nurse B is the secondary nurse who validates that everything is correct. You need to record baseline vital signs, as we said, and typically that's recorded here on the transfusion record, and the date is put there, the time the infusion is going to start, patient's temperature, blood pressure, pulse. On this form, it doesn't have a respiratory rate. I would be suggesting that there should be a respiratory rate, and there should be a pain score as well as saturations, because they can all deteriorate markedly if there is a transfusion reaction. Nurse A and nurse B should sign. Any remarks can be made as well. We always apply standard precautions, universal precautions. Hand hygiene is most important. We attach the IV line to the patient and we follow the hospital policy. Most organisations will have different policies. Some require use of personal protective equipment like goggles, a gown, gloves, absolutely hand hygiene prior to commencing the transfusion. Standard commencement procedure: after commencing, you stay with the patient for the first 15 minutes and observe for any transfusion reactions. That again will depend on your organisational policy, but typically the first 15 minutes is the most important time. The transfusion is commenced slowly for the first 15 minutes, and if there are no concerns after 15 minutes, you reassess the vital signs, make sure temperature, pulse, respirations, blood pressure, saturations and pain scores are all within the normal range. Adjust the flow rate to the desired speed if no transfusion reaction occurs. And the desired speed is the physician order. What are some of the transfusion observations that we make? Well, standard time frames typically include recording the vital signs every 15 minutes for the first hour, every 30 minutes for the next 2 hours, and then hourly until the transfusion is complete. Some organisations even have post-transfusion vital sign observations because there can be reactions after the transfusion is completed. But this will depend on your organisational policy, but typically every 15 minutes for the first hour, 30 minutes for the next 2 hours, and then hourly thereafter. What are some of the transfusion reactions that can occur as a result of giving a blood product or blood? Well, you can have mild transfusion reactions, which could include non-hemolytic febrile transfusion reactions, and these can result in fever, chills, anxiety, a headache, tachycardia, tachypnea. And typically they're caused by cytokines which are on leukocytes. A febrile reaction is the most common, and the leukocytes could be in red cells or platelet components, and as I said, can cause fever, chills or rigors. Typically, a fever is defined as being an elevation in temperature of just 1 degree centigrade or 2 degrees Fahrenheit. Then you've got moderate transfusion reactions, and these are allergic reactions. This can result in facial flushing, hives or urticaria, a rash of some kind, pruritus in the form of scratching, itching, and if it becomes more severe, it could result in an anaphylactic reaction, which is the severest type of allergic reaction. And this can result in hypotension, breathing disorders, severe restlessness and anxiety. So allergic reactions may occur in the presence of an allergy-causing antigen within the donor's blood or transfusion of antibodies from the donor who's got allergies. The most frequent reactions, as I said, were fever, chills, pruritus, itching, or urticaria, a rash, which typically resolves promptly without any specific treatment. But look, they may need antihistamines. They may need more severe interventions if it's anaphylactic. However, respiratory distress, as I said, fever, hypotension, and hemoglobinuria can indicate a much more serious reaction. Then you've got severe transfusion reactions. And this is typically going to be a hemolytic reaction or an acute hemolytic reaction. And this can result in low back pain, anxiety, severe, chest pain, chills, fever, tachycardia, hypotension, tachypnea, bradypnea maybe, hemoglobinuria. Now this is a hemolytic reaction that occurs when red blood cells are destroyed, which is really hemolysis. Hemolysis may be caused by interaction of antibodies in the recipient's plasma with antigens on the donor's red blood cells, or vice versa. Antibodies in the donor's plasma with antigens on the recipient's red blood cells. Classic signs and symptoms include fever, flank pain, red or brown urine, we're talking about hemoglobinuria, and other symptoms such as chills, hypotension, renal failure, back pain, chest pain, or signs of, in the worst scenario, disseminated intravascular coagulation coagulopathy, DIC. And this is where, as we indicated in a previous course, that this is the result of an acute hemolytic reaction which can result in bleeding and coagulation simultaneously. Disseminated intravascular coagulation coagulopathy. This is an overview of all the different reactions. I'm not going to go into all of them. I've just given you a brief overview, but a transfusion reaction can be immediate, which results as a result of an immunological response. This can be hemolytic, it can be a non-hemolytic febrile transfusion reaction, it can be an allergic, it can be a transfusion reaction which results in acute lung injury, TRALI, or it may be non-immunological. This is bacterial contamination. The blood has become contaminated in some way, and as a consequence of that, this can result in septic shock. Or it can be resulted to circulatory overload, which can occur in neonates, pediatrics and adults, certainly geriatrics, which we'll discuss in part 3 of this course, or this learn shop. Then you can have delayed reactions, which can be immunological as well, hemolytic or graft versus host disease situations, non-immunological, which can be related to ferrous sulfate or iron overload, and again disease transmission in the sense of HIV, hepatitis, numerous. So how do you manage these reactions? Most of it results in common sense. Your nursing responsibilities, or as a healthcare provider, if you identify a transfusion reaction or you think there's a transfusion reaction, you stop the transfusion immediately. You don't leave the patient, you notify the doctor immediately. You maintain the IV patency with normal saline because you may need to give emergency medications. You record the vital signs every 15 minutes and you check the patient's ID, blood product and compatibility label to make sure they actually have the right blood. Again, which should have been checked prior to starting the transfusion. You've done independent double checking. It should be correct. In addition to that, you notify the blood bank or the transfusion unit immediately so they can check that on their end everything is okay. What are some of the added responsibilities? Now this will depend on your hospital policy, but typically you have to collect a complete blood cell count, CBC. You need to take blood for liver function tests, and you need to do a urine sample, which can be tested in the laboratory. There has to be documentation on a transfusion reaction form of some kind, which most organisational policies have. So for example, there it is. It says here now, if transfusion reactions occur, then immediately do the following. As it says on the form, discontinue the transfusion, treat shock if present, notify the attending physician, notify the blood bank at once and send to the laboratory. All the unused blood, all the tubing, even the needle. You've got to complete certain forms, you get a urine sample and you take venous samples. Typically 5 mils in an EDTA tube. As I said, you place all the transfusion IV tubing, blood component into a yellow biohazard bag because it's blood. There's typically a hazard could be associated with it. You send the blood, you send everything to the blood bank, and you submit an incident form or an incident report according to your hospital policy. Let's just review, because this is really important. What do you do if you suspect a transfusion reaction? Common sense. You stop the transfusion immediately. You don't leave the patient because they've got to rest. They're going to be distressed. You notify the doctor immediately, the responsible physician or the most responsible physician. You maintain IV patency with normal saline. You record the vital signs every 15 minutes and you check the patient's ID, blood product, compatibility label, and you notify the blood bank immediately. Now let's summarise and review. Which of the following is the universal recipient blood group for packed red blood cells? O, A, B or AB? The universal recipient is AB. Which of the following is the universal donor group for packed red blood cells? OAB or AB? The universal donor is 0 or O. Which of the following is the universal donor for plasma? OAB or AB? It's AB. Which of the following is the shelf life for packed red blood cells if stored correctly? Meaning in a blood fridge. A, B, C or D? The correct answer is 5 days. Fever, sweating or diaphoresis, hypotension, chest pain or back pain, anxiety, dyspnea are signs of which type of transfusion reaction typically? They're severe. Hemolytic, an acute hemolytic transfusion reaction. What is the first nursing intervention if a transfusion reaction is suspected? Notify the physician, Record the vital signs, stop the transfusion, hold the patient's hand. You stop the transfusion. A transfusion reaction is most likely to occur within what time frame after commencing the transfusion, if it's going to occur? A, 3 minutes, B, 15 minutes, C, 30 minutes, D, 60 minutes. The correct answer is it'll occur within 15 minutes. And last but not least, which of the following is the IV solution of choice to infuse concurrently, if required, with a blood product? Is it normal saline? Is it lactated Ringer's solution? Is it half normal saline? Or is it 5% dextrose solution? And the correct answer is 0.9% normal saline. Thanks again for following this review. This is the conclusion of part 2, safe blood product transfusions. Now review part 3. And again, if you found this of any benefit to you, please recommend it to your colleagues or those persons that you may think it may assist in understanding. And look, see you in the next one. Cheers for now.